Hello and welcome to Chapter 3. Chapter 3 is all going to be about technology and more specifically health information technology. Now this is relatively new to healthcare when we look at how long healthcare has been going on, and a very exciting field as far as what it can do to transform healthcare going forward. Now we may even have some health information technology folks in our class, so hopefully they let us know and can talk a little bit about their professions. So if there are any of those folks, feel free to speak up through the forums this week and add your perspective. That would be greatly appreciated. But if you think about it, again, this is relatively new on how we are managing this information that we're receiving, which is the amount of information coming through today is so far greater than just what it was 20 years ago. And just to give you a perspective, and especially from the imager's perspective, kind of where I come from in medical imaging, you think about all that information and data that we do with imaging studies that's coming through and channeling through those systems. Quite a bit of data is being generated. I was talking to a friend of mine, and she has been working in healthcare for 47 years. She retires next year. She actually started when she was 16 years old. And she was talking about how they did billing in the early days. And they actually would go around with something almost like a menu pad where the services were written down and kind of marked on what was done with the patient. They would take those down to a central area, and they did have computers. They were one of the first folks here in Toledo to have a computer, and were doing punch cards, which I have a vague memory. Even though I'm old, I have a vague memory of punch cards and seeing those. Laying around various areas as you're wandering around as a little kid. They were little cards that were literally like about this size, and they were made out of like a little cardboard, and they had punches in there, and the computers would read those holes to enter in their data. So imagine that. And now, of course, all of that's handled through optical drives or cloud-based services and much more detail and speed than it was with pieces of paper with holes in them. So really, it's gone a tremendous distances over the years. So let's take a look about health information technology in Chapter 3. So let's go ahead and get started. This week's word cloud is pretty black and white, but for those non-health information technology students that we have out there today, what you see here may seem like a bunch of letters with only a few words thrown in. Don't worry, it'll all get clearer as you read and investigate this chapter. Again, spend some time with the glossary and furthering your understanding of these terms. Now for a little historical perspective on health information technology. In the early 1960s, when John F. Kennedy formed the President's Science Committee to look at innovative ways of emerging technology to improve life sciences. It was concluded even back then using computer technology to record, store, and retrieve and analyze data collected in the course of treating patients could advance future treatments and developments in medicine. The modern data processing techniques that would make this possible eventually. But the development of this technology needed attention and funding to become actual reality. They had the pieces, they just needed to put them together and train the people on how to collect the data and turn the data into meaningful information. It's not an easy task, but it indeed is doable in small steps. In the early 1960s and on into the 70s, had data entry clerks inputting patient information manually right from doctors' annotations. They would build computer data files across all patients. If computer was programmed with treatment protocols for specific conditions, it could make suggestions for treatments based on the data in the system. A study was done at one such facility who utilized this very early form of health information technology. The facility had agreed upon a list of treatment protocols for particular conditions and found a 29% improvement in the adherence of those protocols when the physicians were given the computer-suggested treatment for that particular malady versus those who did not get the suggestions from the computer. When the PC came along in the late 70s and the early 80s, paper can be done away with and physicians could start to interact directly with patients' electronic health records. These early developments in health information technology were generally custom built for the institution. ID departments chose their own software and built their own programs. Since they were mostly unique, these systems could not communicate across institutions. Portability was not happening, at least yet. Now let's move to the 1990s and the commercially produced electronic health record systems. These systems were far less expensive and could communicate with each other, but still only just each other. So you'd have System A could only communicate with another System A. System B could only communicate with systems from, let's say, B, and then so on and so forth. But B could not communicate with C, and C couldn't communicate with A. So you had a lot of these proprietary systems. So the Office of the Office of the National Coordinator for Health Information Technology, or more simply, we'll just call it the ONC, says there are 200 unique systems right now in use today. But there is a solution to overcome this obstacle of all of these multiple systems. Regional Health Information Organizations, or here comes another acronym for you, the RHIOs, and Health Information Exchange, or HIESs, facilitate the exchange of patient information across different platforms, but we'll have more on these later. The Health Information Technology for Economic and Clinical Health Act, or HITECH, was enacted in 2009. The purpose of it was to get buy-in from physicians and healthcare organizations in the adoption of electronic health record by way of financial incentives. The provisions of the Act are specifically designed to work together to provide the necessary assistance and technical support to providers to enable coordination and alignment within and among states, establishing connectivity to the public health community in the case of emergencies, and assure the workforce is properly trained and equipped in the meaningful use of EHR. The HITECH Act will indeed help providers learn and navigate EHR successfully. The issue lies in the fact that all EHRs do not communicate with each other, again, not quite yet. There are three key components to the success in HIT implementation, and they are technology, that's one, policies and procedures, I'll count that as 2, and culture, 3. The technology has been available for the past 40 years, so we have that. But it's now just being utilized in the clinical health setting. More challenging are the policies and procedures because they can and do vary from facility to facility. If you worked in multiple healthcare facilities, you can probably have seen this and know this to be true. They can even vary within the same healthcare network, which I've seen here at where I work at Mercy Health. Culture brings its own degree of difficulty in implementing HIT. Getting buy-in from administration and staff is the most critical step and can be disastrous if handled incorrectly. Another barrier has to do with money. It's incredibly expensive to implement HIT, and EHR systems, but only the cost of the hardware and software and any of the other incidental remodeling, rewiring, but the training costs can also be high. So again, we got the physical pieces that are coming in, but the training of the individuals can also be as expensive as what you're bringing in. Systems do pay for themselves, though, over the years, but it can be a financial hit to a system when you first start out. Over the years, the cost savings are in the work hours saved and the paper purchased and the storage expenses for the data, and all these savings are appreciable again over time. The other benefit is the reduction in medical errors, which has its own cost savings and probably outweighs everything else altogether. Neatly tucked inside of the HITECH Act are the Medicare and Medicaid incentive programs that revolve around certified meaningful use of the electronic health record. So what exactly does the government mean by meaningful use? In order for providers and hospitals to receive their incentives, money, they must demonstrate that they are meaningfully using the electronic health record by meeting thresholds for specific objectives. Now, the objectives are in 3 stages, so let's go through each one. Well, stage 1, it includes objectives for capturing patient data and sharing the data in a standardized format with patients and other healthcare professionals. So maybe you've noticed that your health system that you're receiving all of a sudden now has a web portal for you to use. Well, that's because of this. They want to standardize that information and be able to share it with you. Now, to receive the full Medicare incentive, they must have applied for this by 2012. The maximum amount decreases every year and stops totally in 2015. All right, so let's go on to stage 2, and that includes objectives for advanced clinical processes. Now, stage 2 began not too long ago in 2014 for the full Medicare incentive. And again, remember, even though we're talking about Medicare and Medicaid here before we go on to stage 3, so much everything else will follow through what's coming through with Medicare and Medicaid. So even for private insurance companies will follow after this as well. Then we have stage 3. Now that begins this year in 2016 and includes objectives which cover in measuring and reporting patient outcomes. So there are the 3 objectives in the 3 stages. They're kind of summarized. There's also a Medicaid incentive program where providers can capture the maximum incentives even if they don't certify meaningful use until 2016. Providers who certify after 2016 do not receive any incentives, 0, from Medicaid or Medicare. Now, your text does a really good job in demonstrating the tables in there, who's eligible for professional and hospital, and more particulars on the 2 incentive plans. So please do look over them and how that all works. As we all know, almost none of the commercially available electronic health record systems on the market can talk to each other very effectively. This is a problem. This is a very big problem. I would say it's the greatest aspect of the EHR is its streamlined patient care through portability. I mean, that's what it's meant to do. So after 50 years of collecting patient data and electronically, it still can't easily be shared. So it's still soiled, as far as the ultimate goal here. There are several reasons why this is so. One is healthcare data is extremely complex. There's been no standard way to store and access the information because systems in individual networks have been customized to satisfy their own needs and not the needs of other or outside networks. Also, the size of healthcare data is immense. HIPAA is another factor too. Although systems are being able to truly share patient data across institutions, if that could even be done, you could have some institutional fear because they may see their HIPAA data as a possible liability for exposure and having HIPAA violations, which could, I guess, mushroom and flower, and if for any reason that it was, your valuable information is now shared on another network that you may not have control over. Now, one answer to these obstacles is the Health Information Exchange. Again, another acronym here. We have the HIE, which is an administrative counterpart to the Regional Health Information Organization, or the RHIO. Now, these two entities work in unison to deliver patient data safely across different platforms. So think of them as brokers or go-betweens, or translators or liaisons or whatever makes sense to you. But the HIE is the one that does the most of the grunt work. It's like the worker bee. It does the actual exchange of information from one setting to another. The RHIO is kind of the administrative side, or the queen bee. It's making sure that all the worker bees are doing their things and all the I's are dotted and T's are crossed. Now, the RHIO creates systems and agreements, processes and technology to assist in the exchange of the information. Again, and that the exchange, actually the execution part of it, is done. The grunt work is done by the HIE. Now, the ONC is funded by the RHIOs to develop and test national standards for the HIE. The ultimate goal is creating a national health information network, which would be a network of regional networks. If every vendor could work towards a common standard, life would be so much easier. I guess think of it this way. Many of us have iPhones, or you have a friend who's had one, and you know that the iPhone is a very closed system, and only certain apps work with iPhones, iPads, Apple TV, or whatnot. Their universe is very tightly controlled on what apps are in there. Now take Android on the other hand. Android is used across multiple devices made by multiple manufacturers, and their apps work slightly differently on some of the equipment out there, and some not so successfully. So you got these two systems, and they kind of take a different approach, and they don't necessarily, one app on an Apple won't work on an Android. Kind of similar what we have here in trying to navigate all of these this information to exchange between the two. So the EHR and the HIE relationship is suffering from some of the same sort of kind of complex issues. So without a standard communication between the two different platforms, it becomes very complex. And you need to account for all of these different formats. The 1990s brought a solution to the problem with older health information communication with the development of a standard called, get ready for it, Logical Observations, Indexes, Names, and Codes, or LOINC. Now, I'm going to pronounce this term LOLINC. HIT students, if you're an HIT professional out there, please correct me if I'm wrong. The purpose of it, though, is to assign an identifier code to data, such as blood chemistry, which can be recorded in many different formats. There are 70,000 defined codes for uniquely reporting lab results and clinical observations. Now, your text gives examples of, I think, 419 different codes for reporting blood pressure alone. The LOLINC library allows computers to receive the blood pressure data to generate exact interpretations. This is called systematically interoperability. The image on this slide demonstrates this, I think, quite nicely. The table is showing 4 different facilities reporting on the same thing: hemoglobin, A1C, and B, or comma B. This entity is different in-house code for hemoglobin A1C. The central clinical lab needs to send the information to Kesson about the patient's A1CB. If it is transmitted, the information using the number as the identifier, as you see, the numbers are not the same, and incorrect information would be sent, causing the patient unsuccessful treatment. By using a low-link identifier code, the correct information would be sent because the number is the same, so the patient can be treated successfully. Another code standard is, again, get ready for it, Systematic Nomenclature of Medicine, or SNOMED. I'm going to say SNOMED. What SNOMED does is specifically identify tissue pathologies. SNOMED clinical terms, or SNOMED CT, is standard for clinical observations. Both standards were developed by the American College of Pathologists, or CAP, C-A-P, and they are the ones that update the SNOMED CT codes. Keeping track of these and the other 200 or so standards in the Unified Medical Language System, again, a lot of alphabet soup here, the UMLS. Now, this is built and maintained by the National Library of Medicine, and the UMLS is the Metathesaurus and toolbox for mapping between and the discovery of over 200 biomedically related terminology standards. The last thing I wanted to do is to go over the different types of HIE designs. We have the monolithic and the federated. Let's talk about the monolithic. The monolithic model is a design where all member institutions periodically send copies of their clinical data to one central repository where all the data lives together in one format. Okay, so here we go with the good news, bad news again on this system. The good news is the data all lives together in one format, meaning it can be maintained in one place and one format. That's good. The bad news is the frequency which the members update their data can vary, making the HIE potentially out of date. Also, aggregating data from multiple institutions creates issues possibly with HIPAA regulations, particularly who is responsible for the quality of the information in the database. And then there's the issue of limited availability of contributing institutions' control over their data. Now let's talk about the federated model. This is the model most used in design. Contributing members maintain control of their data for which they are responsible for under HIPAA. The data resides in the institution system, not as a collective. The HIT database is small, contained only a master patient index, or MPI, housing the different identifiers for each patient in the form of a unique patient medical record numbers, along with basic patient information to make differentiating patients possible. One of the advantages of the federated model is institutions retain complete control of their data. Institutions like that, they like to maintain control. This greatly simplifies HIPAA regulations. Administrators like that. A data breach in a federal model is attributed to the institution and not the HIE. So you have some containment there. The other advantage is trans-institutional data is up to the minute accurate because each user time, each time a user, I guess, requests access to it, the clinical data from all institutions are assembled in real time. Well, again, I want to thank you for joining me. I know this lecture has a lot of terms and words in it, but I just want to go over some of the sticking points in the chapter, only because the understanding and keeping it all straight, all these acronyms can be very, very daunting. Don't let it throw you. Again, we want to give you a good overview of what these things are. In the back of your text, there's a great little acronym index, so take a look at that. While it doesn't provide descriptions or definitions of the term, it does tell you what the letters stand for, and quite frankly, I use it all the time. It helps me, especially in the realm of HIT. And again, also, I think it's very helpful, for yourself. So take a look at that. Again, remember, if you need help, I'm only a text message away, so please text me if you do have any questions. It's the best way to get them answered, and to do so hopefully relatively quickly. And just remember, if you do have a question, there's probably quite a few of you that do have the same question, so don't be afraid to ask. If I do see something in there, if I have a couple of you text me on the same question, I will put the answer often in the course news, or I'll shoot a quick video and trying to address that quickly, because if one or two of you have the question, then there's probably 9, 10, 12 of you that have the question. So excellent. Well, thank you very much for watching today's lecture, and I'll see you in the next lecture in Module 3.